So from a pharmacological approach, we want to think about our older adults, right? So older adults are going to be most likely initiated on these products. And in general, they're going to be a little bit more sensitive to the adverse effects and impact of medications. So starting low and titrating and considering if retitration is appropriate if someone stops for a period of time is important. Success is defined as less than or equal to 2 points reduction of their mental status exam. So if their MMSE is less than or equal to 2 in a year, that's good. That means that we are likely slowing that progression. Okay, so that's important to note, the less than or equal to 2. If it's 3 or more points after treatment for 1 year, we want to really try to consider changing up our treatment, trying to use an alternative agent. So if they are kind of holding steady, if they're doing all right, the treatment duration is kind of indefinite. So we'll keep people on medications, usually for the rest of their lives. If we do alternate agents, there is a consideration to essentially wash out between transition. Because again, the risk versus benefit, we want to make sure that the individual tolerates the medication well. That's one of the challenges that I've run into when using or starting cognitive enhancers in our older adults is, they can be pretty sensitive to some of the side effects. So our options, we have our amyloid beta antibodies, so aducanumab and lecanemab. We have acetylcholinesterase inhibitors, so donepezil, rivastigmine, galantamine. And then we have NMDA receptor antagonist, memantine, and a combination Nimzeric, which is memantine and donepezil. So donepezil is part of your top 200 commonly used products, so important to be aware of a little more details about it because you're going to run into it fairly frequently. And we're looking at where these fit in recommendations. I picked a couple different guidelines that speak to the utilization of these products. So when we think about mild to moderate, right? So those, reductions that are still kind of above that 18, acetylcholinesterase inhibitors are going to be kind of your mainstay of treatment. Where anti-amyloid antibodies fit here, likely in that real mild cognitive impairment, right? Because that's how it's approved. But we don't 100% know yet exactly where the best place and timing and utilization of these products are. So there is some modest efficacy for acetylcholinesterase inhibitors. Which agent is kind of up to the individual. But again, like I mentioned, donepezil is the most commonly utilized. From moderate to severe, memantine starts to come into play. So memantine is only FDA approved for moderate to severe, so more significant dementia. Now, sometimes I will switch someone from an acetylcholinesterase inhibitor to memantine, even if they are mild, because of tolerability issues. But we can talk a little bit more about that when we go more specific into the agents. Things that are recommended to avoid. Vitamin E. I didn't even talk about vitamin E because it really has been pretty much debunked as appropriate for use in Alzheimer's dementia. Aspirin doesn't seem to have a benefit specifically for Alzheimer's disease, but if someone had a cardiovascular event and has ASCVD, then it might be appropriate to use, of course. Same thing with statins if they have another indication. Estrogen has thought to have some protective properties in other mental illnesses, but doesn't seem to be beneficial in Alzheimer's dementia. And then the Canadian guidelines do suggest against use of valproate for agitation aggression, which you will still sometimes see used. And of course, thinking about using medications appropriately for treatment of depressive symptoms. Most speak to antipsychotics as an agent or a group of agents that should be used with a lot of caution because of the risk versus benefit of using antipsychotics for dementia is not as positive as antipsychotics for other types of indications.